Good afternoon, everybody. I'm Daniela Ionescu, and I would like to start by thanking the organizers for inviting me to this traditional and prestigious meeting. I am thrilled and honored to be part of the faculty and to share with you the views on this topic. As conflict of interest, I have nothing to declare regarding related with this topic. Now, the hypothesis that anesthesia may influence cancer biology and outcome after surgery is intriguing and is supported by most of preclinical data and an increased number of retro and prospective clinical studies as well. And I hope you agree that this hypothesis is indeed intriguing. However, scientific arguments still mostly come from preclinical studies, so the results cannot be fully translated into clinical practice, at least at this moment. The good news that there are big RCTs on the way, and there are still many unanswered questions regarding this topic. This is a very nice picture of the network by which surgery, volatile anesthetics, and some of the analgesics influence immune system and cancer cells. And I've just added the possibility that surgery direct release cancer cells into the circulation, or the effect of propofol on both immune system and cancer cells, as I'm going to speak about in a moment. This is the overview of the topics I'm going to get through during my presentation. Now, when speaking about anesthesia and cancer, mosaic effects must be mentioned from the beginning because it is not only one effect, but many of them. And these effects may take place on host immune response or may be present in cancer cells. So anesthetics may target natural killer cells and other population of lymphocytes, interleukin production and inflammatory response, phagocytosis, and lately it was demonstrated that some of the anesthetics may interfere with neutrophil extracellular traps formation. In cancer cells, anesthetics may trigger apoptosis or cytotoxicity, or may interfere with proliferation, migration, invasion, microenvironment, or they can have genetic effects interfering with microRNA synthesis or alteration of DNA. Regarding propofol and immune response, most of the in vitro studies published so far, they demonstrated that propofol enhances natural killer cytotoxicity, has possible interference with net formation by decreasing netosis, decreases pro-inflammatory cytokines like, for example, IL-6, or inhibits prostaglandin synthesis or COX activity by having antioxidant properties. In cancer cells, propofol suppresses hypoxia-induced factor 1 and 2 alpha, and by doing so is decreasing migration, invasion, proliferation, and angiogenesis in cancer cells. Propofol also induces MAP kinase signaling leading to apoptosis, has anti-angiogenic effects by decreasing the VEGF released from cancer cells, influences migration and adhesion by decreasing ICAM, VCAM, and E-selectin, and upregulates a certain number of microRNAs leading to inhibition of cell proliferation and a decreased level of MMPs, at least for 2 and 9. This is a very interesting figure, a very comprehensive one, on the effects of hypoxia-induced factor at cellular level and on the function of the cancer cells. And I've just pointed out the effect of propofol on both hypoxia-induced factor and on angiogenesis. And going into the cell, this is a very nice network of the whole mechanisms by which propofol may suppress oncogenesis. And I underlined in red probably the most important ones, like NF-kappa B, MMP synthesis, P53 synthesis as well, while propofol is increasing, promoting caspase activity, leading to apoptosis in cancer cells. I mentioned the possible role of microRNAs. Is it coming up in the last years? And here is a very nice publication by Ishikawa and Dachingma, and they are showing a number of the microRNAs that are upregulated by propofol, and by doing so, it interferes with angiogenesis, cell proliferation, migration, and metastasis, and cell survival. And in the same publication, they actually are imagining in this picture a comparison. They are comparing inhalation anesthetics with intravenous anesthetic in terms of the effect on cancer cells, normal cells, and immune cells. And you can see that as compared to intravenous anesthetic that are down-regulating cancer cells, intravenous anesthetic upregulates the immune cells or stimulates the immune cells, while the inhalation anesthetics have almost on all the cells inhibitory effects. Now, what are the evidences behind these mechanisms? Although it is very hard to select the most representative article from sometimes a big number of articles on the same topic, I would like to select some articles to prove the mechanism I've just mentioned. So regarding propofol and immunity, this is one of the first studies published by Rivka Melamed and Ben Eliyahu in 2003, and they compare propofol with other anesthetic agent, and they have proved that propofol significantly decreased lung tumor retention and increased the natural killer cell activity as compared to the other inhalation agent in a murine model of breast cancer. Since then, there is a number of years, but it is in 2020 that these authors found the same effect, this time in gastric cancer patients, when they reported that propofol increased the function of natural killer cell and apoptosis rate, although in this patient with gastric cancer, as baseline, the cytotoxicity of natural killer cell was significantly reduced. So these functions of N-kappa cells may be increased with propofol anesthesia. However, there are studies which didn't find any result, any such difference, like for example this one in breast cancer, where the authors did not find any difference between propofol and sevoflurane in terms of natural killer cell count, apoptosis, and cytotoxicity, and the same for cytotoxic T cells. This is another study finding that propofol significantly decreased ROS, reactive oxygen species, and IL-6 level. And speaking about IL-6 level, our group in Cluj, have demonstrated the same thing, not only for laparoscopic cholecystectomy, so a smaller operation, as you can see on the right side of the slide, but for open colorectal surgery for cancer, like you can see on the other side, where the term of comparison was isoflurane. But the impact of this finding on long-term outcome would have to be established by other studies. I mentioned the interference between propofol and NET production, and here is a very nice study published 2 years ago, where the author demonstrated that propofol decreased significantly the formation of netosis. And here on the right side, you can see again the significantly decreased netosis when combining cells with propofol. Speaking about the effect of propofol in cancer cells, this is one of the studies demonstrating that propofol reduced hypoxia-induced factor synthesis and expression as compared to isoflurane in a dose-dependent manner, and the similar findings were reported by other studies in other types of cancers regarding hypoxia-induced factor. On the other side, propofol directly inhibited proliferation of cancer cells, and here are two studies, one in colon cancer and the other one in gastric cancer cells. The first one was published by our group, and we demonstrated that propofol significantly inhibited in a time and dose-dependent manner the proliferation of two types of colon cancer cells, while propofol did not affect the proliferation significantly, the proliferation of fibroblasts, in an attempt to have a mechanistic representation of the microenvironment. On the right side, you can see the effect of the similar effects of propofol on proliferation of gastric cancer cells, and it was published by these authors. I mentioned the microRNA and the fact that propofol upregulates a certain number of microRNAs that are described here in this very nice review. While on the right side of the slide, you can see those microRNAs that are downregulated by propofol. And this may be another mechanism by which propofol inhibit cancer cell proliferation. And here is one of the studies to prove that. The authors incubated propofol with pancreatic cells, and they demonstrated that propofol significantly inhibited proliferation of the pancreatic cells in a dose-dependent manner. And on the right side of the slide, we can see that propofol in the same time significantly increased the expression of microRNA 1338. And in the middle figure, you can see that by adding inhibition of microRNA, the proliferation of the cells was again significantly higher. So the conclusion was that propofol can inhibit proliferation and invasion of pancreatic cancer cells, and one of the mechanisms may be the modulation of microRNA. We are now slightly going toward the clinical evidences, and this is one of the studies, the reference studies done by Donald Buggy and his team, and they taken serum from patients given surgery for breast cancer under sevoflurane and opioids or under propofol paravertebral block. And the serum from patients with propofol paravertebral block demonstrated a significantly increased apoptosis in ER-negative breast cancer cells as compared to sevoflurane. So, going to the clinical evidences, the cornerstone was the study published by Wickmore in 2016 in anesthesiology. Retrospective studies on nearly 7,000 or 6,000 patients, if I'm remembering well, and they found that patients undergoing surgery for different types of cancer had an increased overall survival after propofol as compared to inhalation, and the same results were registered even if taken in consideration presence or absence of the metastasis. So their conclusion was that there is an association between type of anesthetic delivered and survival. Since then, a number of studies have been published subsequently, but this time they were concentrated on a specific type of cancer, like for example this one in colon cancer surgery, when Wu and colleagues published that the overall survival and disease-free survival in this surgery was significantly better with propofol as compared to desflurane. And the same results were registered even if considering the TNM classification of the tumor or the presence or the absence of the metastasis, like on the right side of the slide. So their conclusion was that propofol anesthesia for breast cancer surgery is associated with a better survival irrespective of tumor node metastasis stage. The same results have been published by a group from China in gastric cancer patients, a retrospective study this time as well, and they also demonstrated that TIVA was associated with an improved survival in this patient. The same improved survival and recurrence-free survival was reported after TIVA as compared to volatile anesthesia in esophageal cancer surgery, also in a retrospective observational study like this one, published again in the same years, by Yoon in the same years. However, there are studies that did not report any difference between the two types of anesthesia, like, for example, this one in breast cancer surgery, when there was no difference. And this one, very well-known study published by Daniela and Breast Cancer Recurrence Collaboration, where they compared in a prospective randomized controlled trial patients having propofol paravertebral block with patients having general, namely sevoflurane and opioids. And they did not find any difference between these two types of anesthetics in terms of breast cancer recurrence. The same results, namely no benefit for propofol TIVA, were reported 2 years before, this time in patients with non-small cell lung cancer surgery, also in a retrospective analysis. Now, the last 3 years were the years with reviews and meta-analysis of the studies published so far. And as you can see, the first one was published by Juan Cata and colleagues. And as you can see here, for breast cancer surgery, almost all the study did not report any difference between these two types of anesthesia, while for digestive cancers, most of the authors reported an increased survival, overall survival with TIVA, like, for example, for cholangiocarcinoma, colorectal, esophageal, or gastric cancers, or hepatocellular cancer. But the results were not so homogeneous when speaking about recurrence-free survival. When pulling together more types of cancers, majority of the authors, or two of the publications, better said, reported better outcomes with TIVA as compared to volatile. 1 year later, Chang and colleagues published this systematic review and meta-analysis of the studies published on this topic, and they found that for overall survival, patients having TIVA had an increased, significantly better outcome as compared to patients having volatile anesthesia, while for the recurrence-free survival, the results were not statistically significant. But the author said that the magnitude of the effect of TIVA on recurrence-free survival was actually the same like for overall survival. So it is probably the sample size was not adequate to have significant results. At univariate analysis, again, for digestive cancers like colorectal, gastroesophageal, hepatobiliary, or esophageal cancer, again, the results of overall survival and recurrence-free survival are in favor of TIVA as compared to volatile anesthesia. So the conclusion of the authors was that propofol-based TIVA is generally associated with a better overall survival than volatile anesthesia during cancer surgery. It is this year that a review of the current publication took in consideration not only volatiles, propofol, but lidocaine as well. And the authors demonstrated that actually most of the studies reported potent anti-tumor activity with lidocaine, while with sevoflurane or isoflurane, the angiogenesis was significantly increased as well as tumor proliferation. For retrospective clinical studies, the same authors found that for pancreatic colon cancer, the results were in favor of TIVA as compared to volatile, while for breast cancer surgery, there was no difference between anesthetic techniques. So their conclusion was that that available evidences from experimental studies as well as from clinical studies indicate that current data are only sufficient to generate a hypothesis, just I mentioned at the beginning of my talk, but future studies will have to bring more results and more light on the impact of the anesthetic technique on the outcome in cancer patients. For breast cancer surgery, it is a recent review gathering together all the publication on the topic. And as you can see here, almost all the studies reported no difference between the two anesthetic techniques. However, the conclusion of the authors was that further such trials are needed for the development of systemic breast cancer therapies. What about lidocaine? Although it may be not directly related with propofol, there are studies comparing these two drugs. There are studies adding lidocaine to propofol or to volatile. And finally, there are similar mechanisms of action of lidocaine and propofol on cancer cell biology. So I will end up my presentation with a few words about lidocaine. IV lidocaine was given for quite some time for analgesia, for anti-inflammatory effects, but it is only in the last few years that in vitro studies have demonstrated that lidocaine has anti-proliferative, anti-apoptotic effects, induces angiogenesis, and inhibits invasion of cancer cells. And here is a very nice network of the mechanism that lidocaine is using to decrease proliferation or to inhibit cancer cell biology. I underlined in red some of the most important as they are noticed by the literature, and I added a couple of other mechanisms coming from different studies, like for example, voltage-gated sodium channel that may be actually one of the most important mechanisms for which, because of which lidocaine inhibit cancer cells proliferation. And please take a note that there are some similar mechanisms between propofol and lidocaine in terms of interfering with cancer cell biology, like an increased apoptosis, decrease angiogenesis, and decrease MMP and anti-inflammatory effects. There are not many studies with lidocaine. This is one of the first, and it's a very nice study using in vitro and animal model. And the authors in hepatocellular carcinoma, and the authors demonstrated that lidocaine significantly decreased proliferation of hepatocellular carcinoma in a time and dose-dependent manner, but they use very high doses of lidocaine as those compatible with TACE in clinical practice. In animal models, the effect was similar in terms of tumor growth, but it is interesting that by combining lidocaine with cisplatin, the effect was much augmented as compared to each drug taken alone. They concluded that lidocaine may exert potent anti-tumor activity in hepatocellular carcinoma. The same year, actually the same month, our group in Cluj, have demonstrated this time in an in vitro study that lidocaine had the similar results on hepatocarcinoma cells, but we have used much lower concentration, much lower doses of lidocaine as those clinically effective plasma concentration of lidocaine. And one of the mechanisms for having such inhibitory effects in our study was the decreased expression of p53 in hepatocarcinoma cells. 2 years later, Donald Buggy and his team compared lidocaine with propofol in a murine model of breast cancer surgery, and they have demonstrated that both lidocaine and propofol significantly decrease the number of pulmonary metastatic colonies. So they concluded that both lidocaine and propofol reduce metastasis, but further studies are needed. And it is also Donald Buggy and Thomas Wald this time, including in this narrative review all the mechanisms and the effect of lidocaine in vitro and in clinical studies. and they showed that lidocaine in most of the studies inhibited cancer cell proliferation or metastatic count. So they concluded that the intravenous infusion of lidocaine administered perioperatively may act as a simple, inexpensive, and effective chemotherapeutical agent. Regarding this, we published in 2020 our first study, our first randomized controlled trial together with Donald Buggy's team on breast cancer surgery, where we were having 4 study groups, 2 with sevoflurane, with 2 with propofol TIVA, and added or not lidocaine each type of anesthesia, and we aim to determine VEGF alpha VGA plasma levels, as well as MMP3 and 9, and MPO and H3 citrulline, the last 2 as surrogate markers of netosis. And we found that by adding lidocaine to both types of anesthetics, the levels of H3 citrulline, MMP3, and MPO or significantly decrease as compared to not adding lidocaine, while for VEGF-A and for MMP9, there were no differences between study groups. So we concluded that the addition of lidocaine to either volatile or propofol IV anesthesia reduced expression of netosis and MMP3 as marker of metastatic risk compared to not adding lidocaine. The same year, in 2016, we have started this study, and we published the study protocol only this year, this time on colorectal cancer with the same 4 study groups, but this time the lidocaine infusion is for 48 hours post-operatively, and we hope to publish in the near future the results. We have so far 300 patients included in the study. And it is this very big randomized control study, VAPOR-C study, aiming to enroll nearly 6,000 patients with colorectal cancer and with lung cancer, having the same 4 study groups, 2 with sevoflurane and 2 with propofol TIVA, added or not lidocaine, and hopefully the results of all these studies will bring more light into which anesthetic technique has a better outcome in cancer patient, and if by adding lidocaine to each of the anesthetic technique, we can get some extra benefits in terms of outcome. So in conclusion, propofol TIVA is generally associated with better overall survival than volatile anesthesia during cancer surgery. However, at the moment, there are not enough evidences to support a change of clinical practice, and future large-scale, high-quality randomized trials are warranted to confirm this effect. Propofol anti-cancer effects may be tumor-dependent, as well as time and dose dependent. And when speaking this, I'm thinking of the breast tumor studies, for example. And in the meantime, the effect of opioids in cancer cells must be also considered, but this is a separate topic. With IV lidocaine, preclinical data show that lidocaine has antiproliferative effects. These effects may be, again, tumor, time, and dose dependent. Prospective randomized trial are very much needed, and hopefully they will bring light on this topic. And it will be very interesting to find out if IV lidocaine associated to either propofol TIVA or to volatile anesthesia may have different or similar effects. And with this, thank you very much for your attention, and I'm looking forward to your questions.